امبارح كان أهم أبديت شفته في الانترناشونال كراتيكونس أكاديمي. سي تاك هو ايه السي تاك ده؟ ما كنتش أعرف ايه هو. فلما شفت المحاضرة، وطبعا أنا هزعت جزء كبير منها، طلع اللي هو زراعة الحلقات بالقرنيه، اللي هو زي كيرز مثلا تقريبا، أو باللينيا، اللي هو المحاضرات اللي كانت موجودة في عرضها برضو دكتور مازن، واتعرضت في الجمعية الرمادية. فهي نفس الفكرة، هي برضو نفس الفكرة، بس ده الأجنبي. فده مبدئيا كده مقدمة للكلام.
We're using a 4mm, and we mark the area where we want to then center the laser. I showed creating the channel with the femto laser. And then we're able to dissect that channel. These channels are 200 microns deep into the cornea, so they're pretty shallow. So in some ways, they're like dissecting a LASIK flap. The key is you have to dissect the whole channel because you have to be able to place a soft inlay through it. And unlike the synthetic inlays that we use, which can open the channel themselves, this can't. But the nice thing about these inlays, because they are gamma irradiated, they have a structure to them. They do have some structural integrity. And with these C-Tech forceps, you're able to really slide them and guide it through the channel. And it really does slide in with a little bit of counter pressure relatively easily. So once you have good dissection of your channel, you can really advance it and then smooth it out, and it really takes on it really is that simple. So sorry that this one is a little bit slower, but again, the key here is really taking a look at the plan at the bottom left, and then once we create the inlay and then you place the inlay, we'll see that we really are able to, using the marking set, using the optical zone markers, we're really able to get these inlays into position pretty much exactly to the specifications of the plan itself. And so this is a patient right after CTAC, and you can see how much flattening that we're getting. You can see why this creates such a regular shape to the cornea. Eventually, over time, the epithelium usually fills in a little bit of that ridge area that you see right in between the CTAC inlay and the cornea itself. But you can see such a much more regular shape, and this is right after the inlay is placed. So patients will come back and really notice the visual results almost immediately. So within the first day or two, as they have the inlay in place, they will come back and tell you, my vision is so much better. And for some, that's really better in terms of the quality of their uncorrected vision. For a lot of them, even, they'll say things are so much more singular and so much less basically aberration to their vision, that even with uncorrected vision that might not be to us what we would be consider adequate, they notice how much better it is. So with that, I'm going to turn it over to John to go over some of our results.
Awesome. So we did this clinical trial. We started this, 2021, I think. Basically, what we were looking at here is a prospective version of this. So we looked at 21 eyes of 18 patients. We were lucky enough to have this on the cover of JCRS. Basically, what we saw in this was the uncorrected visual acuity of these individuals improved by, on average, 6 lines. So a very, very impactful procedure. But what I want you to note is as we go to the right here, you can see that the majority of the patients are 6 lines and even greater. So this is a really, really impactful procedure. You're even seeing almost like that LASIK wow factor in these individuals where they wake up the next morning, they come in for their post-op, and they go, wow, I can really see. Now, the other portion of this that's very important is the corrected spectacle visual acuity, right? In these individuals, what you found was about 3 lines of spectacle visual acuity improvement. So if we're looking at this, these individuals are going from about 20/80 to about 20/40. So when we look at a 20/40 eye, that is a functional level of vision for many of these individuals. Some of them could even drive after this. So we're looking at individuals who, really have an improved quality of life. How many individuals in the room see a patient with keratoconus and that patient tells you, I cannot function when I take my contact lenses out. Go ahead, show hands. Yeah, there we go. Okay. So when you see these individuals, what we're doing with this is really giving them back the functional level of their comprehensive visual needs, right? We look at these individuals and say, hey, we're not just going to improve your vision in your contact lenses and that's it. We're able to give you back some of that vision when you wake up in the morning. We give you some of that vision when you take your contact lenses out at night. The other thing that we want to point out here is the manifest refraction spherical equivalent. So you can see that we've reduced this quite a bit. We're looking at almost a 5 diopter change going towards plano for these individuals. So again, very impactful. And when we look at the topographical descriptions here, you can see that we're looking at a mean K flattening, which really matters because that's right over the pupil, of about 8 to 9 diopters, and a maximum K, interestingly enough, of only about 7. But the portion that we really care about, well, in some of this was max flattening, which you could see about 16 diopters on average. But that's not really what we care about. What we care about was that we could totally customize this to the individual, right? The way that we're using the system is to be able to make various different arc lengths, thicknesses, diameters, all the parameters that control the shape of this tissue to be able to create variable amounts of flattening to be able to tailor to the individual's amount of keratoconus that's present. So what you can see here are 3 different eyes, and you can see in their preoperative, you can see an individual who's severe, an individual who is kind of advanced, and then somebody who's very mild. And you can see based on these treatments, we can change them 24, 10, or almost 5 diopters there to be able to tailor the amount of flattening that we're getting and the area of flattening. And what you'll find is the K values on all these individuals and their central Ks are actually relatively similar after the procedure. So we're getting good results or customizable results for those individuals. So I'm going to go ahead and pass this one back to Dr. Greenstein to go ahead and talk this case through, and we'll go from there.
So we're going to go through a couple of cases from our clinic, but this was a 26-year-old firefighter who was having some difficulty with his contact lenses given his profession, and really was looking for options and he was really looking for options to get more functional visual acuity, both without glasses, but particularly in. Whether you're treating somebody who's more mild, moderate, or severe, we are really now able to get a reproducible flattening in most patients. And that is what is driving the visual results. That's why we're seeing the visions that we are. So this patient did incredibly well with CTEC. His uncorrected vision became 20/20 -2 in the right eye, 20/30 -2 in the left, with a little bit of additional correction in glasses. Obviously, for somebody who's a firefighter, this changed his life because he actually really didn't even need much correction at all. And there's really nothing for a keratoconus patient on the surgical side that can do this. Whether we're looking at synthetic ring segments like Intacs, and even topo-guided procedures, which likely would require a lot of tissue removal for somebody with this level of keratoconus, there's nothing really out there that can give this kind of visual correction. Then looking at another patient here. So this was a 38-year-old male. He had had a transplant done in his left eye, and actually had Intacs placed in the right eye and was complaining of poor vision. We had placed his Intacs years ago in his right eye, but he was still complaining that the vision in the right eye was poor. And you can see that he has a lot of anisometropia here. His best corrected vision in glasses is 2400, 2040 in his left eye. He was not a contact lens wearer at all, it just wasn't a conversation for him. But he was really asking for what can he do to make things better for that right eye. So the first question was, well, is he really doing worse after the Intacs was placed? And the truth was, he was doing worse. When I look back at his best corrected vision, it wasn't that much better, but it was better than it was now. And now he actually has much more significant anisometropia after the Intacs placement than he had before. So he really is one of the patients who had Intacs placed and really did not get the results that we were hoping for. So for him, we removed his intax segment, and I've done this now in about 5 patients. We remove the segment, we make the patient wait about a month to let the topography settle down, and then we rescan them so that we can get a new CTAC plan for this patient. Again, the depth of these inlays is much more shallow than intact, so the channels don't tend to override at all, and these are much wider channels. So you're able to do that. The only piece of exchanging intacts for CTAC that you have to navigate a little bit differently from a regular CTAC procedure is the incisions, because what ends up happening is you have your incision from placing intacts, you have another incision for removing the intacts, and now you're going to place another incision to be able to put the CTAC. So you have to kind of, normally, at least when I remove intacts, I try to put an incision kind of right up against the intacts segment, make it nice and easy to kind of find it and take it out. But with CTAC, if you know that's your plan moving forward, you do want to sort of plan a little bit where you put your incision so you can actually get as much of the inlay in place as possible. But as you can see, with the CTAC inlay compared to where he was, this is now with the intacts removed, again, we were able to get a very reproducible, more regular stigmatism with central flattening. And if you look at the difference really from his post-intacts result and post-CTAC, the post-intacts result wasn't that bad. It was pretty regular, but he really just didn't get enough flattening. So that's why he was very myopic and really didn't get a very good correction, because he still has a lot of irregularity in the pupil itself. But with the CTAC inlay in the pupil itself, he has a much more regular topography. And when you look at his vision, now he's 20/60 spectacle corrected. So if you, so if we compare from his intacts result, which is 2400 with a lot of anisometropia, to now his CTAC result, where he's 20/60 with much, much less anisometropia, we have now saved this patient from having bilateral PKs, which is obviously, of course, something that we do for some of our patients, but this has a much more likely long-term better result. So one more case here.
Perfect. So this is actually, I think, an extremely important case to share, because this is an 18-year-old male, unable to function, needs to be able to drive for the job that he really wants to do. When we look at his eyes here, I really want you to notice the thicknesses and the severity of the level of keratoconus that he has. Really, when we look at those, and we'll show them in just a sec, but we'll review that in just a second. Main thing that we want to notice here is his uncorrected visual acuity, his hand motion. Best corrected spectacle is 2200 in each eye. When he wears a scleral lens, he's 20/40 and 20/60, so he's just barely making it to getting a license, right? Now, when we look at his topography, he is very severe in his level of keratoconus, specifically in this right eye. And when we look at the thickness overall at 330, our options are very limited for this individual. And think about the age. Really, we only have the option of a penetrating keratoplasty for this individual, possibly a DULC. But if we start that process of keratoplasty, this individual being so young, the likelihood of needing multiple of these is relatively high. So when we look at this, this was after the after the CTAC procedure. You can see we almost end up with about 30 diopters of flattening on this eye, about 20 diopters of flattening on this eye. When we look at the curvature changes that are created here, they're very, very functional. So if you take a look at the right eye, we're going from having this hyperprolate bulge to having a much more smooth profile, and in the left eye, just essentially removing some of that inferior dive and getting more of that symmetry there. When we look at the epithelial remodeling, the important thing to note is what's happening next to the CTAC inlay. What we can see is the stacking of the epithelium, which creates that smoothing effect. And when we look at this in his postoperative data, his uncorrected visual acuity is now 20/60 in the right eye, 2200 in the left. Spectacle visual acuity is now 20/40, 20/80. But with a soft lens, he's able to achieve 20/30 plus, 20/50 plus, and in that same scleral lens, 20/25, 20/30. So when we look at this, this is a hugely, hugely impactful improvement for this individual. we're being able to give them the option of not just glasses, but also soft contact lenses and scleral lenses to be able to meet their needs. So this is a very, very impactful procedure for them. Now, two things that I do want to mention in this is many individuals will ask, well, this tissue that you're using, are you using fresh tissue to be able to create this? Well, really what we're using is what would have been, essentially discarded tissue. These are essentially the caps off of EK tissue. So we're being able to extend the gift of donation to multiple recipients by using this process. So it is an extremely impactful procedure here. So in summary, really high impact. It contributes a lot to the comprehensive visual management of these patients. Using the femtosecond laser, in this case the Zemer Z8, it really allows for this full customization. And by using these tomography-driven algorithms that we've developed, we're able to create not just parameters to these inlays that are going to be consistent, but also give you consistent surgical plans to be able to show consistency from surgeon to surgeon. One of the best things that we've seen so far was at ASCRS. Bill Wiley showed his clinical data, and it was mirroring ours, which is really impactful because variability from surgeon to surgeon certainly showed different outcomes with things, other sorts of inlays out there. So with that, thank you for your time.
They're not working. Now they're working. Okay, good. So we do have a number of questions that have been posed. First of all, let me ask you this. You're out there training surgeons at this particular point in time. How many surgeons currently have been trained in CTAC in the United States?
So I think we're up to about 10 or so early adopters who were our first group of surgeons that we really wanted to see, again, whether this was reproducible. Was it just something that we were able to do, or could other people do it? Starting in June, it's going to be available to any surgeon who wants it in the U.S.
Fantastic. Fantastic. The other thing I noticed, so in the outcomes, you had significant reduction in myopia, but the astigmatism factor wasn't changed as much. Can you comment on its effect on the cylindrical component?
So when we look at the cylindrical component of, there we go, okay. When we look at the cylindrical component of this, what we're seeing is really more regularization of the cylindrical. So what we're seeing is less asymmetry between that, which is making it a more correctable amount of astigmatism. Now, when we do look at this over time in larger amounts of correction, we are seeing a reduction in the amount of cylindrical correction that is present. But the most important portion of this is more so that it's symmetric now, allowing it to be corrected.
I think it also depends on the starting point. So in the more mild cases, we're really seeing a reduction in the cylindrical correction as well as the myopia. In the more severe cases, we're kind of seeing more of a spherical equivalent that is improving, but they do maintain a reasonable cylindrical correction.
Great. Let's see. Oh, that's a great question. There are a lot of questions. I don't think we've had this many. Can I answer all of them? Yes, we understand. We can't answer all of them, but I'm going to try to pick out the ones that I'm interested in. So, yeah. Thank you. Okay, so how does CTAC play a role in progression of keratoconus? Is there any stabilizing effect?
So it's a good question. I mean, right now, we do not say that CTAC is a stabilization procedure. With our patients who we think are progressive, we absolutely recommend that they have cross-linking done. We are currently doing it simultaneously with the CTAC inlay. We've done it on a lot of patients who we've already done cross-linking for. We have some surgeons who have adopted it who are doing it afterwards. Having said that, I do think that adding this tissue to the cornea in the way that we are is probably improving some of the structural integrity of the cornea. So I think that is probably what is happening, but we don't really know that yet, so we would not advocate to not do cross-linking.
Okay. John, I'd like you to answer this question, and that is, what makes scleral best-corrected visual acuity improve after CTAC?
Yeah, so the interesting thing on this is, you're not only getting an anterior surface change, but you are getting a mild posterior surface change as well. You're getting way more of an anterior surface change, though, because it's 200 microns deep. But we do have some posterior change, and that's going to change the posterior aberration profile. And when you're masking the anterior cornea with your scleral lenses, you are getting some level of posterior aberrations that are then coming through. So that's where things like, the reason why we have improvements with our wavefront guided lenses and explains kind of the residual aberrations in those. But in this, because we are improving that posterior geometry as well, we are seeing a slight improvement in the visual acuity there. Now, what you'll note, though,